Hello, my friends and my colleagues and my fans. To continue talking about this, my second episode, talking about acute chest pain or medical causes of acute chest pain or acute chest pain of non-traumatic origin. In continuation of what I was talking about, the cardiac causes of chest pain, I already finished talking about the more serious and life-threatening causes of cardiac causes of chest pain, and I said the most important cause of chest pain are cardiac, and these are usually the most serious and most life-threatening among the causes of acute chest pain. And then we have the non-cardiac cause of chest pain. To finish the cardiac causes, we are left with the entity of pericardial disease as a cause of acute chest pain. Pericarditis is also another important, although less common than ischemic heart disease, chronic and acute ischemic syndromes. It is an important cause of acute cardiac chest pain or acute chest pain of cardiac origin, acute pericarditis and subacute pericarditis. And these are usually after traumatic. We are now talking about the medical or non-traumatic causes. The most common is related to inflammation of the pericardium due to an infectious cause, like patients with viral pericarditis, which is the most common cause of infectious pericarditis, viral pericarditis, usually related to certain types of viruses like the echovirus, like the Coxsackie, different types of Coxsackie viruses, like respiratory syncytial virus, echoviruses, Epstein-Barr virus, hepatitis viruses, cytomegalovirus. These are all types of viruses which might involve the heart and cause acute viral pericarditis. Acute viral pericarditis. We have also bacterial causes and mycotic infections which might involve the heart, but these are less common. And here the acute pericarditis may also be associated with myocarditis at the same time. Same viruses which cause acute pericarditis that might involve the myocardium. And so there will be what we call acute myopericarditis or perimyocarditis in the same patient. That is inflammation of the pericardium and at the same time inflammation of or involvement of the myocardium by a viral inflammatory process or virus-induced inflammation of the myocardium and pericardium, and here there will be pericarditis. Pericarditis commonly present with chest pain, which is more related with or increased with breathing, and it is usually stabbing or dull aching in nature, and increased with coughing and with movement of the chest and with breathing. And this characterizes the pain of acute pericarditis, and it is more commonly on the left side related to the precordium, rather than being central. Central is more the status in acute MI, but in pericarditis more over the pericardium, and it's increasing with cough and with breathing, and this is important features of the acute pericarditic pain. Commonly associated with the pain of pericarditis is shortness of breathing also, and sometimes also cough. Pericarditis may be complicated by pericardial effusion. So pericardial effusion, or even in some cases patients with pericardial effusion with even cardiac tamponade might also present with chest pain, but the pain of acute pericarditis is more acute, more severe, more sharp, and increases with breathing and coughing, and usually associated with other manifestations like, as I mentioned, respiratory manifestation, chest pain, maybe fever, maybe dyspnea, sometimes with arrhythmias in association, sometimes with changes in the heart sounds. Depending on the degree of inflammatory process within the pericardial sac, which is the sac surrounding the heart. And when the pericarditis is very severe, it might be associated with overflow of fluid inside the pericardium, and here this is what we call pericarditis with effusion, that is with pericardial effusion. These also can be diagnosed by the ECG changes. ECG changes, by the way, can diagnose acute pericarditis by the elevated ST, but it is the ST elevation is different from the ST elevation of MI, because the elevation in pericarditis usually diffuse, while the ST elevation of MI is usually localized to the site of ischemia, maybe anterior elevation, maybe inferior elevation, but in pericarditis it is rather diffuse in all the leads of the ECG, and it is with concave upper margin, not convex. The one of MI or acute coronary syndrome is rather convex. We call it curved ST elevation, but here it is concave elevation of the ST segment, and also it is more widespread, but in the acute MI it is localized to the site of occlusion, depending on which artery is occluded. Because in pericarditis, simply the pathological process more widespread, affecting the inflammation affects the whole pericardial membrane and sac. It may be complicated with effusion, and here there will be other pathological changes and other clinical features of pericardial effusion, especially if the effusion is rapidly evolving and rapidly progressing and become moderate or severe, and will encroach on the heart, causing what we call cardiac tamponade. And this is a form of restrictive heart disease, so cardiac tamponade. So pericardial effusion with cardiac tamponade. So these are overlap syndromes. We might have pericarditis with effusion, we might have effusion without tamponade, and we might get effusion with cardiac tamponade. This depends on the degree of pathological involvement of the pericardium, depending on the underlying pathological disease which caused the pericardial disease. But pericarditis can be one of the causes of acute chest pain. Pericardial effusion and tamponade are usually associated with chest pain, but rather dull or aching, not that acute. It has another type of chest pain, which is dull chest pain. It's rather dull and vague chest pain, different from the sharp acute one of the acute pericarditis. So any pericardial disease can cause, ranging from the acute pericarditis to pericarditis with effusion, then to effusion with cardiac tamponade. These all three categories of pericardial disease, they might be complicated by chest pain, but the character of pain and the type of pain different, as I mentioned. So pericardial disease, pericarditis, is one of the cardiac causes of among the causes, not only infections, also autoimmune pericarditis, which characterize the Dressler syndrome of acute MI, which is one of the complications of acute MI, immune-mediated pericarditis complicating MI, and this we call it Dressler syndrome, which might happen 1 week to 3 weeks after the onset of MI, and also presents like any pericarditis with chest pain. So a new chest pain or another evolving chest pain, different from the chest pain of acute MI, developing after 1 week or 10 days, might point to the possible development of a new complication of the acute MI, which is pericarditis complicating MI. We call it the Dressler syndrome. It's an acute immune-mediated pericarditis complicating acute MI as one of the late complications of MI. Of course, we all know that the most common complications of MI happening early after the onset of infarction are arrhythmias and pulmonary edema due to left ventricular failure. These are the commonest. And of course, the most drastic, the cardiogenic shock, if massive acute myocardial infarction, massive, involving more than 60% of the cardiac muscle. So arrhythmias, left ventricular failure, and pulmonary edema and cardiogenic shock are the most important acute early complications of MI. Late complications are the Dressler syndrome. One of the late complications, Dressler syndrome, or reinfarction, or extension of the infarction, or recurrence of the infarction. So acute pericarditis complicating MI is also common complication, late complication of MI, and it is not infectious in origin, it is immune mediated in origin. So it is another type of pericarditis complicating acute MI. So pericarditis, whether bacterial, viral, immune mediated, also the pericarditis complicating Collagen vascular diseases, immune-mediated diseases, it's one of the cardiac features of SLE, of lupus, of mixed connective tissue disease, of overlap syndrome. So it is also, and here we call it immune-mediated also pericarditis, complicating immune-mediated or as a part of the systemic involvement of immune-mediated collagen vascular diseases, as for example in SLE, systemic lupus, and mixed connective tissue disease and connective tissue overlap syndromes. In some types also of vasculitic syndromes. So this is the cardiac causes of chest pain. Then we come to the non-cardiac cause of chest pain, and these are related mostly to the lungs. I will talk about the lungs now, and then in the third presentation I will talk about other non-cardiopulmonary causes of chest pain. About the pulmonary causes of chest pain, the most common, of course, is pneumonias. Pneumonias can cause chest pain by causing pleurisy. So, pleural disease complicating pneumonia, whether synpneumonic or parapneumonic pleurisy. So there will be pleuritic, classic pleuritic chest pain, which is usually hemithoracic and which is usually stitching in nature and increasing with cough and increasing with inspiration due to friction of the two layers of the pleura, the visceral and parietal, with movement of breathing and movement of the chest wall with breathing. So here it is unilateral, it's not precardial, not precordial, not central, it is rather unilateral hemithoracic affecting part that's lateralized on the right or left side and usually stitching and usually increasing with coughing and inspiration. So pleuritic chest pain due to, this is a mechanism. How is pneumonia associated with chest pain? But the pneumonia itself without pleural involvement usually does not cause chest pain because lung tissue is painless. But when complicated by pleural inflammation or pleural involvement, the chest pain will appear. Here will be evident clinically. In patients with severe lung infection, a deep, vague chest pain might be sometimes felt, different from the pleuritic chest pain due to involvement of the pleura by synpneumonic or parapneumonic pleural effusion and pleurisy, complicating pulmonary infections. So this is the pneumonias as a cause of chest pain. Other causes related to the pulmonary tissue, the vascular tissue, is massive pulmonary embolism. Massive pulmonary embolism can present with massive, severe, and sometimes dull chest pain, which is mostly central. So massive pulmonary embolism is a cause. Moderate pulmonary embolism with pulmonary infarction can also cause chest pain, but less severe chest pain. So pulmonary embolism, whether moderate or severe, can cause chest pain with different character. Also, patients with tension pneumothorax, they can present with chest pain, usually unilateral on one side, and it's dull, aching, and increasing. Tension pneumothorax is another cause of chest pain and chest discomfort, severe chest discomfort and chest oppression. So beware of the tension pneumothorax and the massive pulmonary embolism as causes of sudden vague chest discomfort or chest pain. Tension pneumothorax and massive pulmonary embolism, in addition to massive myocardial infarction and massive lung collapse, total lung collapse, they cause classic clinical picture of acute chest discomfort or pain associated with acute dyspnea, cyanosis, and shock and circulatory failure. So be careful, because these four conditions need to be differentiated from each other. Acute MI, massive pulmonary embolism, tension pneumothorax, and massive total lung collapse. They can produce more or less the same picture of chest pain, shortness of breathing, cyanosis, and shock with circulatory failure. So they are life-threatening conditions which might cause cardiovascular collapse, and they should be differentiated from each other. Acute MI, massive pulmonary embolism, tension pneumothorax, and massive lung collapse. I mentioned them here among the causes of acute dyspnea and among the causes of acute chest pain or severe acute chest discomfort. This is the pulmonary causes and the cardiopulmonary causes of acute chest pain. Wait for me for the third presentation for the other causes of chest pain.